all the deep breaths. Good evening, if you're here to join us. We've had, obviously, some slight technical issues. I may have to go and, I'm not going to say shout at my child, but politely remind them that it's way past their bedtime. So if I'm suddenly escaping, that's the reason why. What we're going to do is we'll give it a couple more minutes and then we will kick off the software that I was using. Decided not to connect to my YouTube account, and seeing as I've sent everyone the YouTube link, that was a slight issue. But anyway, we'll give it a go. At least we've got screen share this time. And whoever you are, lovely person on YouTube, thank you very much for signing in. We'll get this going. We'll give it a couple more minutes and then we'll sort of set off from that way. Would you mind just dropping me a comment just to say that you can hear me okay? I mean, I'm hearing okay this end, but that is really not helpful. And also I'm on a dual monitor setup, so hopefully that should help things out. But anyway. Yes. See if we recognise the name. Good evening. Who's that? AP. Oh, pleasure, AP. Looks like it's going to be a one-on-one session, but hopefully amazing. So we're already quids in from last week, which was an absolute abysmal, but I've found it funny. And AP, can you just see the screen as well? It should have the other 20% terrible tables on there as well. Right, AP. Amazing. So we're already 3 steps ahead than we were last week. So should we kick off? What do you reckon? Just the two of us. We can make it if we try. So this one, let's talk through terrible tables. So effectively with terrible tables, I had a good registrar of who I was mentoring for their April AKT, who basically turned around that they got confused with sensitivity and specificity and their 3x3 tables, your case control studies and your cohort studies as well, because they're all presented frustratingly in exactly the same sort of manner when you try and revise for them. So let's try and sort of mitigate against that and see what we can do from that aspect. And it's really frustrating, and I'd never ever thought of it like this way before, because for me, I'm like, well, yeah, I can do it, I'm happy, I've done my exams. And then she turned around and said, like, they all look the same, it's really confusing. So let's go through with it from that way. So let's start with sensitivity and specificity, and the best way to think about this is to get your mind in the right frame of mind, and it's all to do with timings about when this happens. So to get a decent sensitivity and specificity, for a start you need to have 2 tests, okay, so a simple one and a complex one, and they need to occur at the same time. Okay, so the simple ones, I often think about it, is what can I request in GP land? That's the really sort of simple one from that way. So blood tests, examinations, point of care testing, they're your simple ones from that way. And then you've got to reflect that against complex tests, and generally they are what's considered in-hospital ones, okay? So it's one of those of, you've got your GP test and then I'm going to refer you off to somewhere else. So your classic ones with breast cancer, so examination, I felt a mass, okay, and then you're having a mammogram, okay, from that way. PE, your D-dimer versus your CTPA, pneumonia, your point of care, CRP versus your chest x-ray and full blood count, and then classic one, prostate cancer, your PSA versus your pelvic MRI. Okay, now when you're presented with the question, sometimes what they'll do is they'll swap the complex test into, actually they've just said, look, there's no point in pushing it further, so let's just say, look, that's the end of it. Like, you have reached the limit of the investigations that we're going to do. So you've effectively got the disease. So, for example, you may have an examination of a breast lump versus breast cancer. So they get rid of the mammogram, they get rid of the ultrasound, the fine needle aspiration, just say you've got cancer. Likewise with prostate, you're saying instead you've got PSA versus you've got prostate cancer. Just be mindful with that. You'll start to hear things about your true positives and true negatives, and these can be really confusing if you haven't got a quick rule about them. So from my point of view, the easiest way to think about it is think of it backwards. So the last part, so the positive or negative, is talking about what your test is showing you within primary care, within GP land. For example, I've got a raised PSA, so that is a positive result, okay? Whatever marker it is or whatever line you've set, it is over that line, so it's positive, and if it's under that, it's negative. The first part, the true, false, is whether do they match up, okay? So you've got a raised PSA and they've got prostate cancer, that is a true positive, okay? So likewise, you've got a negative result, and does it match with them not having prostate cancer? So not and not equal together, so it's a true negative. Marvelous. You can get it slightly sort of different, where people can sometimes get confused, is where you get what's called a false positive. So this is where you have, say, a raised PSA marker, incredibly common. You go through to have all of the investigations, and then effectively you do not have prostate cancer. Okay, so you've gone through all of these investigations and it comes out that you don't have prostate cancer. So that is a false positive. Positive because your initial investigation was true in terms of like you've got cancer or you've got a raised PSA. You've gone through all of these investigations and you find out that you don't. So your initial investigation does not match the final outcome. And likewise with a false negative. So you may have a negative test initially. You go through all of this investigations, or to be honest, you're not going to have any investigations, and it crops up a couple of however long later, and it turns out that actually you did have that disease, the cancer, etc. at that initial bit, and it was just missed. From the data provided, then we can prevent, everyone sort of harps on about four things. So sensitivity, specificity, positive predicted value, negative predicted value. There is a fifth, and the reason why I'm going to say about the fifth is because this popped up in my AKT, and I was mortified that I hadn't got a blinking clue how to calculate it until I sort of took a deep breath, tried to figure it out. And so I do not want any trainee to go through that again. So we're going to go through those 5 calculations that you need to be able to get out from this. So your first one, let's get the table set out. So on your left-hand side, you've got the columns with test positive and test negative. And then across, as you move to the sort of the middle column and the next column, it's disease present, disease absent. And so you can see you're playing this matching game. So you've got your first initial column. Let's see if we can get here. So you've got your disease is present, test is positive. You've got a true positive, disease present, but the test is negative. So this is your false negative. And then you've got your disease absent. You've got your false positive, so because the test is positive. And then lastly, you've got disease absent and the test is negative. So they both agree. So that's a true negative. So that's the way it needs to be set out. So sensitivity and specificity specifically look at the disease. So sensitivity is looking at how good the test is at predicting people with the condition. Okay, so it's your true positive divided by your true positive plus false negative. And your specificity is how you rule people out of the condition. Okay, and depending on what you want to do, depends on how good or how useful the investigation is. The classic one is your D-dimer. Okay, it is very good at ruling people out. Okay, so if you've got a normal D-dimer, the likelihood of you having a blood clot is slim to none. Okay, happy days. The problem is the sensitivity is that it picks up loads of other bits and pieces. I always remember a case where I had someone where they were pregnant and they got chest pain, and we were like, right, they could have had a PE, they're at high risk. And then the labs turned around and said, no, we're not doing your scan until they've got a D-dimer. And I'm just like, you're an idiot, basically. I didn't say that to them. I would never be so disrespectful to my colleagues, but I thought that in my head. So let's go through. This data is taken from the Liverpool study, so at the height of COVID. And what happened here was that effectively they got a population of nearly 3,000 and they placed them through effectively one after the other. They did a lateral flow in one test, so a quick and easy, simple test, and then literally moved them next door to do a PCR. So lateral flow, PCR, off you go. Thank you very much. And the question is do they agree with each other? How good is the lateral flow versus the PCR at picking up COVID? Okay, and we all know that it wasn't brilliant. So this is the actual data from it. So what we can do is we can work out the sensitivity. So it's true positive divided by true positive plus false negative. So basically this first column here, happy days. So 22 divided by 45 in total, which gives us 0.49. Huge point for the AKT. Make sure you look at, or they will say how they want this expressed. Okay, so they will say whether it's due to whether they want a percentage or a decimal. They will say it in the actual question answer box, and make sure you read that. Likewise, the specificity, looking at the negative findings, so how good it is sort of ruling out. And you can see here that actually it's quite good at ruling out COVID. So what we're looking at then is going across the way is what's called the positive and negative predictive value. And all we're looking at then is how accurate is a positive result and then how accurate is a negative result. Okay. So it's similar sort of metric in terms of what we're looking at. So for a positive result, we're having the 22. So your true positives at the top divided by the total of that row. Okay. So 92%. So pretty good, which is then the statisticians and the people I tuned into during the height of COVID were questioning then, based off this data, why was the government insisting that if you got a lateral flow that was positive, why did you then have to go and get a PCR done? Because it was pointless, because it was such good at testing from a false positive perspective. Okay. And again, you could argue that with the negative, it was showing that it's actually fairly good as well. But we all know that the problem with this data is that it takes a unselected population. Okay, and we can do another session deep diving if you so wish on pre and post test probability, is that this does not take into account of people with symptoms, people with sort of other issues as well. It is literally just a group of random 3,000 people, chuck them through and see what happens. Okay, because as you're well aware, the statistics and the likelihood of you getting different symptoms will vary depending on what symptoms you've got, and this does not take that into account, in case there's any confusion. Okay, so prevalence. If you look closely enough, you've actually got, through the PCR being positive, you've got a total of the people with the disease at any one time. So prevalence is a snapshot, okay, or the proportion of a population who have that condition at any one time. So you can work it out. So you almost ignore what the LFT, lateral flow test, shows. You're going straight in for, is it a positive test or is it a negative test? And what's the total proportion, okay? So with this, we're looking at, you've got 45 people with a total with a PCR that's positive, okay? So that 22 plus 23. Now, you just be careful, because this is an easy slip up to make you think, oh, it's going to be divided by all the PCR negatives. No, it's divided by the whole population, okay? So it's 45 divided by 3,026. So the prevalence at this point, and again, read how they want that statistic presented, is 1.5%. Okay, so phew, right, that's one of the tables out the way. So if you're sitting your AKT in April, please be aware that we've got the 20% series, which is a series of guided modules. You've got 10 modules on the statistics, 6 modules dedicated to the admin, where you've got a short video and then a whole load of text and waffle through. So you can either read it, watch it, depending on where you are in your revision. You've got the April Smash, which you can access via the QR code, which for £30 gives you a month's access to the course. I'm just wondering if anyone who's signed in, because I know I've been spamming the people already on the course, has anyone signed up to it here? And tell me how you're getting on. I'm genuinely curious. Please go on. Just put a comment saying it's okay. I will wait patiently. Anyone being brave? If not, we will continue. What I will do is, once we finish the presentation, is that I'll go through and I'll show you what the back end is, and that you sort of like, for those who haven't signed up, what you get for your cash and whether you think it'll be worthwhile for you, which I hope it will be, because I hate people failing the exam. It is just unnecessary for it, and certainly having a high amount of anxiety over the stats and the admin. So let's push on from that way. Again, this is what the back end looks like. A couple of introduction bits, and then a load of questions. You've got a total of 100 questions dedicated specifically on the stats and the admin, just to really boost you up and help you get through. Let's move on to the next one. And we're looking at case control studies. Okay, so what you're doing is you're comparing people with the condition versus that don't. Okay, so this is where you need to start to think about time. So with sensitivity and specificity, if there's anything about that they have had the test and they have got the disease, and that is a snapshot in that moment in time, then you know you're dealing with sensitivity and specificity. If they talk anything about looking back in time, retrospective, recalling, glancing your mind back, or any other acronym or euphemism, then effectively that is all retrospective, and that is all a case control study from that aspect. From a case control study, you get an odds ratio where you can work out the ratio of those exposed to the disease and versus those who do not have the disease. And the problem is that you're presented with a very familiar looking table. Except for there are some key differences from this way. So instead of test positive, test negative, along this side you've got exposure and no exposure. So this could be to anything: new drug, radiation, smoking, you know, whatever environmental factor that they're looking at. And then what you're looking at is your disease present. So is the disease present there? And you've got A divided by C, or is the disease absent there? And what you're looking at is the ratio of these columns. Okay, now if you're mathematically, statistically minded, which, seeing as you've signed in on 8 p.m. on a Tuesday night, then I would argue that maybe not, and you need an extra help, and that's absolutely fine. I would break it down really simply and just do the dividing by those that are in the disease present column, and then divide it by those in the absent column. So A divided by C, and then doing B divided by D. I would do it in a couple of steps as well. So I would get the result for the disease absent first, so A divided by C, B divided by D as step 1, and then divide that result by that result. Happy days. Move on. And just remember, you'll get a ratio, okay, and you get the result. So if it's 1, the two equal each other, and that means no association between exposure and outcome. Okay, less than 1, it's protective, and over 1, there's an increased risk. Now this is made up in terms of this little nugget of information there. So a study looks at smoking and heart disease. The odds ratio comes out at 3. Either the odds of someone with heart disease being a smoker is 3 times as high as those without heart disease, or the odds of someone who smokes as having heart disease is 3 times greater than who don't smoke. Okay, so if you're looking at less than 1, so something's protective, so think exercise, smoking cessation, new drugs, good effects, food groups, okay? If there's greater than 1, then looking at radiation exposure, smoking, new drugs, the bad effects, okay? And food groups, think about, you know, red meats that are always thrown about in the media as sort of being hatred. So we're going to take a made-up example. This is made up. I have got nothing against sausages. I have... You know, I didn't get to this rotund figure without getting my sausage or two. So, public concern was raised about barbecue-style sausages causing an increased risk of bowel cancer when a local barbecue celebrity was diagnosed with the condition. Case control study was conducted to try and work out the odds of this. Out of 110 people who had eaten the sausages, only 10 had developed cancer, and that's, just bear that in mind. So 110 and 10 had developed cancer. This was compared to 300 people who had not eaten the sausages, of whom 100 had developed cancer. What is the odds ratio? Now, I'm being a little bit cheeky from that aspect. Was that how we sort of do this? So taking the first statement, out of 110 people who had eaten the sausages, only 10 had developed cancer. So break this down. I've been slightly mean, just because I can. That actually I've given you the total of people who've eaten the sausages. Okay, so of that means 10 have developed bowel cancer, and I've given you that information there. But what I haven't given you is that actually I've not given you the exact figure for no bowel cancer. And that is obviously, that would be 110 minus the 10 people who develop cancer, no bowel cancer. So it's 100. So the total column is 110, but these individual numbers, you can see break out to there. We're doing the same with the other one as well. Okay, so we've got 300 people in the column as total. Okay, and out of this, we've got 200 people who've not got bowel cancer, and then we've got 100 people who have developed cancer. Again, these are all made up figures just to sort of prove that we can do it. So as I said beforehand, with the odds ratio, we do A divided by C divided by B divided by D. Okay, so we've got 10, let's do the bowel cancer column. So 10 divided by 100, which gives us 0.1. And then let's break this down as well. So 100 over 200, giving us 0.5. So it's 0.1 divided by 0.5, which is 0.2, which again, if you're looking at putting a decimal into a percentage, multiply by 100. So 0.2 multiplied by 100 is 20%. Again, read the question, see how they want it presented. They will say explicitly, express this as ... Okay. So the odds ratio has come back as 0.2, so this is less than 1. So the odds are, it's showing that it's been much lower if you have been exposed. Just be careful, this goes back into levels of evidence. We're still in a very, very low level of evidence that just because there's this link, it does not mean causation, okay? What this will often hint at is that more research is needed, and you cannot, or you've got to be very careful about making big conclusions, okay? And that's where we as scientists need to combat the media, because they'll turn around and say, look, so just a preventative, and you're like, well, actually, the stats don't show that. They show that there's a very low odds ratio for this. So I'm going to touch a bit about DocSupport. You may have seen this sort of floated about and on the initial screen. So DocSupport is combined with GP templates, and we'll all be coming under one banner in the next couple of weeks. So we're here basically to sort of guide you through your medical career. You know, I'm not going to bang on to you how difficult it is to be a doctor at the moment. You know, we've sort of getting all the sort of the GP crises going on and new contracts, etc., etc. I love being an NHS GP. I'm a GP partner. Absolutely love doing it. But I love doing some other bits on the side to try and hopefully boost and sort of support my income. And that's where DocSupport can sort of help you out from that aspect. You've got free resources available and also several number of ebooks, and you can go and have a look, docsupport.co.uk. Do it after this live webinar, not now. Please don't leave me. And also you've got upcoming webinars, which are sort of hosted here. I've left the QR codes there for you. So if you're looking at, Dr. Matthew Wickham, who's my partner in crime, he has set up his own, he's a GP, fully qualified, but he is an ENT trainee. So he has got his own private GP clinic with a heavy hint of ear, nose and throat. He's doing a setting up private practice on the 29th of April, but he has gone through to set up his own private clinic, and instead of pulling up the drawbridge and not being nice about it, he's basically said, right, come on, let's pull people along. I've given a chat about starting on YouTube. We've got stuff as well looking at CQC compliance as well, which is a huge component. So just trying to help you think ahead of your career. So lastly, let's touch on cohort studies. Okay, so cohort studies, it takes a series of people that are exposed to something and watches them over a long period of time. This is what we often call a longitudinal study. There's a high risk of confounding as no one is put into different groups or randomized. Okay, you are literally just watching as people go through. Classic example is the Framlingham Heart Study. The only thing that you can calculate from this is one of the many things, it's relative risk. Okay, so the probability of an event occurring in the exposed group divided by the probability of the event occurring in the non-exposed group. So again, we're back down to this horrible 3x3 table. Okay, and what you're looking at then is looking to try and get the exposed rate versus your control event rate, or those who have not been exposed. Okay, so that's what sort of you're hinting at from that point. So your exposed is calculated by A, so those who have got the disease and been exposed to it, versus everyone who's been exposed, so A plus B. Okay, You're not exposed then, he says, hoping I've read my slides correctly. Excellent, is basically the same. So your control event rate, and you're looking at those with the disease divided by everything in that row there. What I would suggest, similar with your other one, is that you do exactly the same again. So you take the exposed event rate, calculate that, put it to one side, and then your control rate, calculate that, put it to one side. Happy days. Again, this is made up statistics just for the purpose of this presentation. So you've got here those who are smokers with lung cancer. So let's take the top column. So you've got your smoker here, you've got your lung cancer of 25, and then no lung cancer 75. So the total in this column is 100. And then you've got your control event rate. So you've got 1, and no cancer is 99. So the combination of those is 100. Convert that into a decimal. So 0.25 and 0.01. Okay, so 0.25 divided by 0.01 equals 25. So from this, there is a 25 times greater chance of developing lung cancer in smokers than non-smokers. Again, statistics are made up. It's just to demonstrate this term to help you with your exams from that point. And that's it. In a very, we have rattled through that from that point. So what we'll do is you've got April Smash, which will give you sort of £30 for this one. What I'm going to do is I'm going to leave you with that quote from Tolstoy, and we'll just pull up the other 20% series. And what I will do is take any questions, any comments, concerns, anything about the AKT that's stressing you out, and then I will do my best to help from that point. And whilst everyone is feeling brave, I will share this tab instead. So this is what the other 20% series is. Okay, so you've got your introduction from that point. You've got like my top 10 tips for passing the AKT. So it just sort of rattles through that. Okay, and gives you a couple of pointers in terms of where to go from that point. And then having a look at this, you've got your stats. So you've got your, what I think will give you a good grounding in terms of the admin. The whole purpose then of this is not to make you into like experts when it comes to it, but just really just to give you the confidence so you can go away and do your clinical revising, which constitutes a lot more of the AKT. Okay, so go through all of that. So you've got 1 to 10. I will show you all that, and you've got a scattering of knowledge questions along the way, just to help you out with that one. And then similar here, you've got your randomized controlled trials, for example. And then you can see here, it just goes into a bit more detail about it. So you, depending on how you learn, you can either go away, read it up yourself, okay, happy days, or you can go and sort of have a look at it from that one. Likewise, the admin section does exactly the same. So you've got your Med 3s, your DVLA rules, your aviation rules as well, which are a bit tricky, your patient practice interaction, your GP contracts and all fun things like that. Okay, and then finally duties of doctor, which we covered on the last session as well. Fab. Right. So what I will do is I will leave that up. Has anyone got AP? Thank you for, I'm glad you found that useful. I know it's a sort of short, sharp and sweet, but sometimes that is useful. Is there anything else that anyone wants to run through? Because my kids haven't woken up. Marvellous. Or anything that's stressing you out with regards to the stats and the admin? Because believe it or not, I've got a lot of presentations on this and I'm more than happy to rattle through it for the next 20 minutes. If not, you can have me badgering on or sort of blaming someone else for this. Right. Give it a couple more minutes just in case anyone's typing furiously. And then failing that, we will call it quits there. Marvellous. Right. What I'm going to do is and just say thank you so much for your time, and thank you if you joined me for the last session. So the last session was hosted last week on Thursday, which if you go over to the channel GP templates, you can watch it. It's all sort of live. It's all uploaded there, good to go. From my perspective, what I would say is just make sure just need to sort of make sure that you are sort of you need to sort of catch up on there. Sorry, I'm sort of having some people log into me from that point. Anyway, right. What I will say is, if have a look at the other 20%. I'm going to plan to do another follow-up session next. The plan at the moment is next Wednesday. Keep an eye on the channel because I'll post it on there. We'll aim to do a couple more topics that should sort of help out from that point. Okay, and then we will take it from there. If I don't see you, very, very best luck for your AKT. Good luck.